that we are all excited that this is the holiday season and so much going on, and I really appreciate that you have made the effort to be here today. And a couple of announcements to make before we get started. One is it's a special day today. We want to acknowledge Angelina Co's birthday today. And also, one of our team members, Zuli, is not here today because it is a very special day for her. And Tanya, can you tell us a little bit about why Zuli chose not to be with us today?
Yes. Zuli is our Continuum of Care coordinator and helps facilitate all of these meetings. She is out today because she is having, or she's at her graduation ceremony. She's obtaining her master's in public administration. She had her hooding ceremony just 2 days ago. So yeah, we're excited for her, and I appreciate you taking this time to recognize her. Thank you.
We are wishing her the best today. We will call the meeting to order. If we could have roll call, please. Ariel?
Good morning, board members. We'll start off with Mayor Jim Steiner.
I'm here, but I'm no longer the mayor. I'm the mayor in recovery now. Just a council member.
Got it. Thank you. Good morning. Supervisor Karen Spiegel. Here. Dr. Matthew Chang.
Here.
District Representative Daryl Fry.
Here.
Bill Blankenship.
Here.
Leticia De Lara.
Present.
Angelina Co.
Good morning. Good morning, President.
Good morning. Dr. Charles Lee Johnson. Claire Jefferson Glipa. Carol Alba. Rainbow Marler. Daniel Johnson. And Karen Roper.
Happy to be here.
Oh, and Greg Rodriguez, not last but not least. Hello.
Okay, so we will make one change to the agenda. We will have 5.2 follow 4.1 because I've been informed that they would make better sense to do it that way. So we will do that. And we will then move on to the next item, which is 2.0 consent items. Starting with 2.1, is there a motion to approve the minutes as submitted?
So moved.
Second.
We have a first by member Roper and a second by member Blankenship. And is there all those in favor? Yes,
I abstain.
we have one abstention. Is there any no's? 2 abstentions. And all those in favor, aye? Aye. It passes. We will move on to the next item, which is 3.0 public comment. Is there any member of the public that would like to speak on items not listed on the agenda, but of an interest to this committee, this board, I'm sorry? Nobody's stepping forward. Okay, Mariel, is there any member of the public by Zoom that would like to address the body?
Seeing none.
Okay, we will move on to the next item, which is 4.0 old business. 4.1 communication guidance for continuum of care notice of funding opportunity related to program changes. And I will turn it over to Tanya.
Thank you, Madam Chair, and good morning, Board of Governance members, Continuum of Care members, and all of our guests who are here with us today. We wanted to speak on the communication plan for our continuum of care in response to the changes in policy to the HUD Continuum of Care program, which, as we discussed during our last meeting, is set to impact or could potentially impact 887 individuals, 640 households that are currently being assisted through the program. I wanted to start off with sharing that since we last met 2 weeks ago, both Roshana and myself recently came back from a convening in San Diego where about 30% of CoCs nationwide came together to really unite and discuss the current policy changes and sort of begin to exchange ideas for a path forward. I also wanted to include that we also had a meeting with the state about a week ago, which included our Assistant Director, Mike Walsh, our Community and Housing Development Director, Juan Garcia, and then we had a representative from RUHS Behavioral Health. I see Marcus Cannon was part of that conversation, in which we were able to meet with the state's California Interagency Council on Homelessness and have again, sort of like a broad discussion on the policy changes and make sure that the state understood what the impacts would be here locally. Of course, they look to us for recommendations. You can imagine the number one recommendation made was for a request for funding. So the state heard loud and clear that, hey, we need dollars, rental assistance dollars, to be able to keep people in housing that are going to be impacted. Number two, asking the state for greater flexibility for uses on any current funds that we receive, such as HAP and ESG that is managed through their office, as well as encampment resolution funds to support individuals who are impacted. So it was a good discussion. I will share that there right, is still, I think this is an ongoing conversation. We are far from a full solution, and as was communicated to each of you, as well as the continuum of care by way of email, on Monday, HUD withdrew their notice of funding opportunity for the fiscal year 2025 continuum of care program, which we're talking about, and noted that, I'm going to read what their statement said online. This withdrawal will allow the department to make appropriate revisions to the NOFO, and the department intends to do so. In the previous fiscal year 24-25 NOFO, the department reserved the right to make changes to the NOFO instead of processing renewals for a variety of reasons, including to accommodate a new CoC program, priority, or new funding source. The department, again, this is HUD, still intends to exercise this discretion and make changes to the previously issued CoC NOFO to account for new priorities. HUD anticipates reissuing a modified NOFO well in advance of the deadline for obligation of available fiscal year 2025 funds. That same day, HUD was scheduled to attend a court hearing with U.S. District Attorney Judge Mary McElroy in response to two lawsuits that were challenging the policy changes, and included a coalition of 21 attorney generals, which includes our very own California, Rob Bonta, and 11 local organizations and nonprofit organizations. The concerns, as this board also shared and as our staff has also shared, are centered around the caps to permanent housing, which are currently at 30%, and would move the funds to transitional housing with some worker service requirements. The judge ordered HUD to return to court next Friday, December 19th, and to address the last minute change. So at the convening that Rashana and I were at this week, what we heard from the previous attorney that represented, the HUD's previous attorney for the previous administration shared that, right, the best educated guess is that that HUD will be releasing the new NOFO with minor technical changes. So this idea that the intent was really to make the lawsuit moot, and a new form of the NOFO will come out with subtle changes and sort of restart the process. All right, but there's also, I think, there was a lot of hope in the room that the withdrawal could also mean that HUD would be going in a different direction and choosing to renew all existing projects and extend sort of like the significant policy changes for a later time. And so again, as staff, as we sort of talk, like these are sort of best educated guesses. Nobody really knows. I think that I know our team is eagerly going to be watching the court hearing on December 19th, next Friday, to get a better sense of direction. So at this time, our recommendation, our staff recommendation still is to continue on our current path. We are not suggesting that we change course. We want to remain aggressive, prepared, and focus on putting together a competitive application. And since we have last met, our team also released a request for information as the board had approved and discussed. We released that last Friday and had the original due date of Sunday, December 14th. But in light of the HUD withdrawal of the NOFO, we went ahead and extended it through Friday, December 19th, the same date as the court hearing. So that is what we know now. Dr. Lee Johnson and the board had directed us to have a plan for messaging to landlords, participants, and our housing providers. And in your packets, you'll see that we included a 2-page document front and back that includes language that would be shared with these 3 separate entities. I wanted to share with you that we are already beginning to work with agencies who have programs with expiring grant dates of January 31st, 2026, so just a few weeks away. This includes RUHS Behavioral Health, Valley Restart, Lighthouse Social Services, and the City of Riverside. Both the City of Riverside and Behavioral Health have agreed to support their clients, at least in the short term, using resources that they have. And our team has been working closely with Valley Restart and Lighthouse to leverage county HAP funds to cover rents beginning in February. I should say that our intent is not to fully tap into county HAP funds. As we discussed during the last meeting, we're going to leverage, right, and turn every single rock, as they say. We're looking at sort of each household independently to see where there are veterans that we can help connect to HUD-VASH, where there are families that we can connect to the CalWorks Housing Support Program, where there are seniors that we can connect to the Home Safe program administered by Adult Services. We actually have a call with them this afternoon. As was recommended, we're looking at where opportunities even come to leverage supportive services provided through our managed care plans and community supports and enhanced care management. And you'll see from the messaging that we included that, right, part of this contingency plan is working with each household to see where individuals can self-resolve, right? Like we are really wanting to make sure that in cases where people are able to absorb 100% of the rent, that is done, to where people are able to identify a roommate and sort of stabilize in that way, that is done as well. And we're even, looking to scenarios where we could be working with landlords to negotiate rent or break leases to help individuals relocate to another more affordable housing unit. We're working with our coordinated entry system. The Continuum of Care approved a policy that allows for these individuals to be prioritized for the next housing unit that becomes available. As you know, the county has been building, and I think we have a course of over 6,000 units in the housing pipeline. So as these units become available, these individuals are going to be prioritized for those units as well. So it's going to be a very diverse approach. And this is the only way that we can really see this working out. There are simply not enough county HAP resources to be able to support the full 887 individuals. So part of the reason and really wanting to keep the meeting today was, one, for transparency, but two, to take advantage of this platform, having you all in a room, but as well as our other providers, and our ask is if you have housing resources, if you have access to units, any type of housing units, if you have partnerships with landlords that we should explore, let us know, because we really want to just compile a list of all those resources and put them in our contingency planning toolbox. We need everyone's help to get through this. Again, is there sort of a hopeful, you guys know I'm a very hopeful person. Is there a side of me that thinks HUD could just come back shortly and decide to renew all the projects? I'm on my knees hoping that's going to happen every night, but as you guys have directed us to, and because you are a group of strategic leaders, we know that we need to be as diligent and aggressive in our approach of sort of mapping all resources available out. So I will share for the public. The messaging documents are also uploaded on the Google Drive. Our plan is, Roshana, to share these with the Continuum of Care next week on Wednesday. And so we're looking for feedback. If there are things on here that are not included, things you don't like, let us know. This is a working document that will be shared once approved by both bodies. Thank you.
Okay, thank you, Tanya. And this is an informational item only, but we will open it up in a minute for comments and questions. And I think what you said about the fact that we need to share this information and why we hold this meeting is to ensure that we are getting the word out to all of our community partners. I'm going to start with turning it over to Greg because he has some questions and additions, and then I'll open it up to the board for comments and questions, and then to the public for comments and questions. Greg?
Thank you, Madam Chair. Just a couple additions. First of all, I applaud the staff on the proactive nature that they're taking in addressing what could be a big problem. In the meantime, I share the same hope that Tanya does, that we are doing lobbying efforts in both Washington, D.C. and in Sacramento, primarily in D.C. to the congressional members to, as they start appropriations for health and human services in HUD specifically, that they look at these changes and the detrimental nature that they will have across the country. On the state level, I'm part of a couple coalitions that are actually already meeting with primarily budget members of both the Senate and the Assembly to express the need to increase the amount of HAP allocation. As many of you are aware, in the budget that was passed in June, they only allocated $500 million instead of $1 billion. That had been the standard allocation. So we're advocating that they up that back to $1 billion due to the fact of the changes in the CoC. And so those efforts will continue, and we'll keep you updated on any progress that has.
Very good. Thank you, Greg. Okay, board members, anybody would like to start us off with questions, comments? Okay, Director Roper.
Thank you so much. Good job, Tanya, and Greg, thank you so much for the comments. I have a couple of questions. One would be to Home Connect. I'm not sure if Marcus would be the one to answer, but we had talked about this before when we were worried about not enough emergency shelter if we were tracking turnaways and knowing the impact to the system. We think about this. Calls going into Home Connect, is there a way for us to figure out how to quantify the impact to the system if people are newly homeless as a result of the policy or people that have lost their housing? And I don't know, you know, call systems are complicated if we're already tracking turnaway data as opposed to just somebody called for this need as opposed to they are newly homeless because of this. Is it sophisticated enough for us to collect data to know the impact of the policy changes? And then I have a second question.
Can you approach the podium, please? And as Marcus is coming up, I do want to make an announcement that we have been joined by board members Carol Albaugh and also Claire Jefferson Kilpa. They both joined us before we started this discussion item. Thank you. Okay, Marcus?
Good morning, Madam Chair. Marcus Cannon, RUHS Behavioral Health. To the question that was put before us, I think we could add a question to our screening tool. We don't today ask any question. We don't anticipate that anyone has yet today lost housing as a result of the proposed HUD changes that, as Tanya mentioned, have now been retracted. So they're sort of proposed rumored HUD changes. But if those changes do come to pass, then yes, we could add a screening question if that would be the wish of this body and our funder, which is HWS.
Well, I know at some point we were worried about enough emergency shelter, like cold weather shelter and people being turned away. So I'm thinking like broader in terms of data that's collected as far as people, because the system doesn't have the capacity to be able to address the needs. So, try to figure out where people are not being able to get services because of the shrinking capacity in the system itself. So sounds like, yes, we could do it if we wanted to talk about different data points to be collected.
And I think if the question is about emergency shelter capacity, my recommendation would be that be brought back as a larger conversation. I think on any given night, we have many callers who say, I can't get into emergency shelter, and yet our HMIS data says that there's open emergency shelter beds. And so that data collection could help talk about some of the subjectivity of that story. Why is it that people feel those beds aren't accessible? But we should also consider that other data point about the fact that there are, in fact, open beds.
Yep. Thank you.
Thank you.
The second question that I had was, Tanya, if let's say for some reason that HUD does pivot, let's just say, the miracle happens and you have the opportunity as a team to be able to look at the renewals, were the renewals pre-vetted so that, from a performance perspective, you could renew all of them and it's like ready to go?
Yes. Well, yes, we have worked with the continuum of care, and that actually ties into the next item. So I'm happy to share some background that every year around summertime, we work with the continuum of care to prepare a project scorecard. And that scorecard is also in your packet and includes measures that align historically with HUD's NOFO. We recently updated it to align with the NOFO that was just withdrawn. But all that to say that is usually done in summer. We've already worked with each project and provided them with a score. And so we have that ready to go in the event that there is a pivot. Yeah.
Thank you. Any other board members? It's Board Member Fry. And then, okay, and then followed by Board Member Cole.
Birthday girl, hello. I mean, kudos again to the county for your pivoting and your resilience and trying to make the best out of this crazy situation. I think the elephant in the room is the fact that people are going to be very frustrated by this. And when I say people, I mean clients, right? So the Home Connect hotline is probably going to be a real hotline, like a seriously, continuously called hotline for it. So my proposal is maybe we can include the phone number for the hotline for it. And then is there any other contacts we can put on the letters for the clients so they can get the support they need for any pivoting they need? But they're also, just want to highlight that they're going to be needing extra support.
Thank you. Do you have a response to that, Tanya? Is it possible to?
Yes, to the Home Connect hotline. I think we want to be very strategic. Rashawn and I spent some time talking about this yesterday and make sure that people just initially upon receipt of notice just don't call the hotline. They're already, I'm sure the Marcus CES team can tell you they already receive thousands, right? Hundreds of calls on a regular basis. So one of the things we talked about was adding exactly what you, Board Member Fry just shared, is certainly their housing provider, the name and contact of the person that will be working with them to look at alternative resources. But two, the contacts for each of the alternative programs, right? If you're a veteran, contact this number. If you are a senior, contact this number. So really as sort of a point reference before, and really noting on the letter that as a last resort, right? If all else fails, here's the Home Connect hotline. So know that as an example with Valley Restart and Lighthouse Social Services, we're literally case conferencing each of their clients, like going through one by one. So it's all that just to share that it's an active process. My hope is that individuals are sort of well prepared before they even receive this letter.
Thank you. Board Member Coe.
Thank you again, and I did what everyone else is saying. This is very proactive, and I think it's very necessary. And I too am on my knees and praying that things pivot and change for the better. Along the same lines is maybe suggesting, I know the different entities like Valley Restart and Lighthouse Social Services were probably already doing this or planning on doing it, but maybe having a town hall meeting for those in those programs where you kind of go over the letter and give them the information so that they don't feel by themselves. Because when you get a letter like this, regardless of where you are and how many people are working with you and you have your provider, I know there's times that people call me, I can't get back to them for days. And I tell them that I will get back to you as soon as possible, or their message gets lost in the ether, or it gets lost in the tsunami of emails that I get. And I'm like, well, I didn't even realize you sent me an email. So it makes them feel even more alone and more isolated and more that fight and flight kind of thing. They're going to disappear. You know, none of these options work for me. I might as well just go back to the streets. So to be proactive, I would suggest having that kind of information. Anybody receiving these subsidies, anybody that's eligible for these programs, here's what's going on. And in a sense of transparency and urgency, not adding more work, but adding more work. Because if you address it as a whole, they can say, oh, well, he's in the same boat as I am, so is she. And what are you going to do? Like, maybe we can get together. It'll also lessen the burden on the provider and the worker, because I'm sure those workers, staff is already overwhelmed, and most of us are understaffed already as it is. And this is going to be right after the holidays. So there's a lot of turmoil happening. This is very trauma informed, and I really applaud that, but let's be more trauma informed. Let's avoid a severe trauma and make it a little less impactful by saying, we hear you, we're here, these are your resources, here's some forms, and make sure they're in different languages, not just English. Just putting it out there. That's just my suggestion, but I really do want to commend you for this. Read through it quickly. It reads well. It makes perfect sense to me, but it might not make perfect sense to someone else.
Thank you, Board Member. Tanya, do you have any thoughts? Okay, thank you. Other board members who have questions, comments? I do want to respond to Board Member Coase, and then I will call on you next. I do think that that's a very good idea, but if we could explore that with the CoC and see how we can approach that. Okay, and next we have a Board Member Jefferson Gilpa.
The other suggestion I would like to make is that we have options besides just phone calls, so that we provide phone numbers, text available numbers, and emails. We know that our families and individuals are largely residing on federally subsidized phone service, which is also not necessarily working in the way we would love it to. So I think just adding every possible way for folks to engage would just make sure that folks are able to get the help that they need during this time.
Thank you. Tanya, do you have?
I agree with all of your recommendations.
Okay.
These are good. Thank you.
Thank you. Any other board member have any questions or comments? Okay, yes, Board Member Fry.
Last comment, because Karen and I dealt with a client who felt like she was being targeted for the lack of funding that was, accessible. So to Angelina's point, like having it feel like it's a group thing, that HUD is, changing it up for everyone, I think is very important for other clients as well.
Thank you. Okay, so if there are no other comments from the board members, I would like to open it up to our public. Is there any questions or comments from our public in person? Okay, moving on to the remote. There's no questions, comments? Thank you. Okay, we will move on to the next item, and we agreed to change the order, and we're going to go to 5.2. Tanya?
All right, so this item is on the agenda. Let me just get it here. So as I mentioned earlier, every year as part of our application process, we work with our Continuum of Care membership body to prepare a project scorecard that has measures that, again, confirms an agency's capacity to administer a HUD grant, looks at sort of their historical experience in doing so, and addressing any deficiencies, and of course remaining sort of compliant with any federal or state rules. We worked with the Continuum of Care to update the scorecard earlier this summer, and the board, you should have access to the scorecards in your packet. To our members joining us virtually, we also included the project scorecards in the Google Drive. And initially, I will say that initially, because we were working under the previous HUD CoC NOFO that was just withdrawn, sort of the timeline, the aggressive timeline that was in there, our need was to bring this before the board to get approval. However, since we have some time and we're acting sort of in the absence of a NOFO, our recommendation is to take this to the Continuum of Care so that they have an opportunity to review the changes. And it works well because we're meeting with them next week. And as I mentioned, that'll give the Continuum of Care a week to sort of make any edits, comments to us that we can incorporate. And then by Friday, again, we're expected to hear from HUD on any updates. I think the last thing I'll say is that the changes we made were only those that were necessary to align with the NOFO. So we basically looked at the NOFO and the scoring rubric that they included. As an example, giving points to agencies who were able to carry out the 40 hours of service or work requirements for transitional housing projects. So those are some of the significant changes, but we also incorporated some points or measures that gave projects or agencies points for having experience administering HUD Continuum of Care programs in the past, as well as workforce and behavioral health services, since those are sort of heavy components. So again, our initial plan was to seek the board's approval and sort of expedite it. At this point, since we have some time with the board's approval, we'd like to take this to the Continuum of Care next week, get their feedback before fully adopting it.
Okay, so with that change, do you still need us to have an action, for it to be an action item?
Shouldn't,
We'll
no.
continue it. Okay, so I'll still open it up for board member comments, questions. Okay, and I will open it up to the public. Is there any member of the public that would like to speak on this item? Okay, none in person. Marielle, is there any? Okay, so there are no comments from so the direction is that this would go will be continued. It will be shared with the Continuum of Care for their input, and then we will probably hear back at the next meeting. Okay, so we will then go back to 4.2, which is an update on homeless housing assistance and prevention, the HAP, round 3 funding for Step Up on 2nd Street. This is no action item. We will start with Tanya giving us an overview.
Excellent. At the last regular board meeting on October 16th, our staff provided an informational update on the HAP round 3 allocation of $389,000 to Step Up on 2nd for street outreach services. During the discussion, Step Up noted that a settlement with and let me provide some background. At that time, we had provided an update indicating that we had paused our contract with Step Up on Second as a result of the agency's pending litigation with the state of California. Eddie Estrada, the vice president of the organization, was present at the meeting and shared that the investigation or litigation targeted Shangri-La, an affordable housing developer, and their misuse of state home key dollars. Step Up on Second was included in the litigation as they were serving as the supportive service provider for that project. And actually, I think there were several projects throughout the state of California. But it's important to note that Riverside County had not had any projects active with this developer. Again, during the last board meeting, Step Up agreed to provide the county with an update. We paused that street outreach agreement until we heard more information. We recently learned that the state has dismissed the settlement against Step Up on Second, and that it is fully resolved. All disputes and claims asserted in the litigation between both HCD, the state's Housing Community Development, and Step Up on Second. And Step Up did not admit to any liability, fault, or wrongdoing. We shared a copy of the dismissal with our county council, and they have given us the green light to move forward. And so at this time, we are currently working now with Step Up on Second to start up street outreach services, which would cover this area of the county and others. And those services are expected to resume on December 16th. I know that Eddie Estrada, again, Vice President of Step Up on Second, is here with us today and can help answer any questions that the board may have.
Thank you, Tanya. Board members, do you have any questions or comments? Okay, we will open it up to the public. Is there any member of the public present that would like to speak on this item? Okay, Mariela, is there any member remotely?
There are none.
Okay, very good. Okay, so I'm glad to see that everything turned out as expected, that we have the green light and we're moving forward. Okay, so we will move on to the next item, which is 5.1, Riverside University Health System Behavioral Health Presentation on the System of Care. Our Dr. Chang, we will turn it over to you. This is an information item, so we will not take action.
Appreciate the time today, and my understanding there is an ask from the BOG to talk about behavioral health and what we do, and so I will attempt to do so as I'm able. So we've entitled this, building the continuum and how infrastructure investments prevent hospitalizations and support recovery. So the first thing, just from a high level, and I don't need this one, put this aside here. So we are RUHS Behavioral Health. So we provide the behavioral health and substance use disorder services throughout the county of Riverside. We do it for folks who are on Medicaid, Medi-Cal, uninsured, and folks in behavioral health crisis. And our lane, such as it is for folks who are deemed to have what's known as serious mental illness. It's a bit of a nebulous term that's been a source of discussion and debate, but essentially, I view it as we take care of the sickest of the sick. So it's all ages, cradle to the grave. And then in terms of service reach, so we have 79 internally run sites throughout the county of Riverside. We have a clinic in Corona. We have a clinic in Blythe and everywhere in between. One of the things that we're proud of is we partner with 140 community organizations that believe in I believe including some of the folks here or on the teams today. We're in 100+ school sites, and that number keeps growing. And also the number keeps growing as we see about 70 to 75,000 folks annually. There are significant challenges, though. I just mentioned we see about 70,000 folks a year, 75,000 folks a year. But based on prevalence rates, we know we need to see an additional 100 to 110,000 population. Part of the challenge is math. We know there's a rising need in the community. Riverside County, as we know, is the fastest growing county in the state and second in the country behind only Maricopa. And with that, if we're adding 30 to 40,000, I think 30-odd thousand folks a year to the county of Riverside, a chunk of those folks have behavioral health needs, and a chunk of those folks require the services from RUHS Behavioral Health. One of the things, if you heard us talk about before, we have an aging behavioral health facility in the city of Riverside. It was built in the late 80s and dedicated in 1991, and since that date, the population has more than doubled. And thank you to the Board of Supervisors, Supervisor Spiegel and the rest of the board and RUHS, but we have tried to pour millions of dollars into it to keep it up to code as best we can. But every time surveyors come in, so this could be CMS, it could be Joint Commission, CDPH, other acronym type institutions, it always ends up being expensive. It ends up being things, ligature risk for furniture. It could be call lights. It could be all kinds of stuff. But the issue is there's certain elements that are just not fixable in the current site. So this includes earthquake readiness, involves cafeteria. So that's a huge challenge. And so we'll talk a bit about what our strategies have been about that. Not enough money. I think this is really germane to the conversation we're having today as we hear about the HUD-NOFO and what's going away, what's not going away, how bad is it going to be. I think that's a lot of the conversation. But essentially, Riverside County is short approximately $184 million each and every year to provide behavioral health and substance use disorder services. I won't bore all of us with a lot of the details, but essentially in the three main ways we're funded, and that's through 1991 realignment, 2011 realignment, and MHSA, we are significantly under equity. So for 1991 realignment, for example, we have about 6% of the eligible population. We get 3% of the funding. 2011, also 6% of the population, 3% of the funding. And MHSA, 6% of the population, 5% of the funding. And, when you talk about, it works out to be a lot of money. And I'm sorry, I don't have this in front of me. I could look at my notes somewhere. But essentially, there are a lot of counties that are over their allocation. And so if we had allocations similar to, I believe it was Contra Costa and other places, we'd have, $300-odd million more a year, each and every year to provide services. We can talk a bit about why that's hard to challenge and to change. I think at a high level, you have 58 counties. We're 56 and 57 out of 58 in some of these funding streams. And so for all of these, you have folks who are way over their allotment, as it were, and so they don't want to revise it and change their piece down. So we develop other strategies in terms of what we're trying to do. Not enough beds, probably not a big surprise to folks in this room, but there is a best practice recommendation. You have 50 inpatient beds per 100,000 population. Riverside County has under 10, and there are 0 kid beds. And for purposes of this conversation, kids are 12 years and younger. And so if you're a kid and you require psychiatric inpatient care, we have to ship you off to San Bernardino, Loma Linda. We have to ship you off to Orange County, maybe to Chalk. We have to ship you to LA. We got to ship you somewhere else because Riverside County does not have kid beds. Not enough housing, which is why we're all here today, and not enough placements as well. And so, we've been very heavily focused on what we can do, right? So I've laid out some of the challenges in front of us. I've laid out the fiscal challenges. I've laid out why the other counties don't necessarily want to give us our fair share. I've laid out some of the numbers in terms of our beds, in terms of our housing, in terms of our hospital, and what we're looking at there. But we do know that every investment in infrastructure is an investment in prevention. And so we've been heavily investing in what we can through competitive grants to build out a continuum of care. So we've built out, I won't go into details here, but everything from mobile crisis teams, urgent care, residential treatment, permanent supportive housing. And this whole idea is to prevent hospitalizations and to keep people connected to recovery closer to home. I think it's a fair statement that there are two sides of a coin, right? If we agree that a bed is a limited resource, and I think we can definitely do that, the two ways, or one of the two ways you can approach it are you can build more, which we'll talk about, and that's what we've been doing, or we can use less. So I'll definitely talk about the build more piece, and that's been possible through great work, through the behavioral health team, Marcus Cannon, Melissa Noon, Amy McCann, Deborah Johnson, Ryan Miller, our whole team in going after competitive grant funds. But I do want to spend a minute in talking about the use less side of the coin, because I think that's it's critical given our position, given the challenges that we face, that we have to tackle both sides of the problem. So in terms of using less, one of the areas we've been focused on are our crisis teams. And so these teams really focus on reducing hospitalization and law enforcement involvement. And again, thank you to Supervisor Spiegel and the board. We were able to get support for different types of mobile crisis teams. But here, there's immediate intervention, there's integration with the community, so collaborating with law enforcement partners, healthcare providers, and other community organizations. As we went into COVID, we had 15 mobile crisis teams spread throughout the county of Riverside. And even back then, they were very useful because they're part of the fiscal piece about this. But they actually won a 2019 CSAC Innovation Award. They keep a ton of folks off the street, out of hospital, out of jail. And we calculated at that point that we were saving somebody, and it wasn't necessarily us, but we were saving somebody over $200 million back when we had 15 to 20 mobile crisis teams. We've now scaled that up significantly. So we have around 50 mobile crisis teams spread throughout the county. And I'll talk a little bit about that piece here too. But so this is a chart of, oh, it's not following along. That one is, that one's not, that's odd. This is a look at 5150s in Riverside County. And so I'll back up a sec. So 5150s are when you place an individual on a civil commitment hold, that's known as a 5150, it's a Welfare Institution Code 5150. And so the green triangles were the 5150s in Riverside County. And what this slide is actually from is several years ago, we met with RCOPS, and I forget the acronym, I apologize, but essentially it's the leadership of the Sheriff's Department and the various police chiefs. And thanks to the support of the Board of Supervisors, we were able to provide more mobile crisis teams, CBAT teams, which are law enforcement ride-along teams, which I'll talk about. But essentially, we went to them and we said, look, the mobile crisis, the 5150s are the purple triangles or dots. The green outline areas were the catchment areas at the time of the CBAT teams. And we said we were able to provide, I think it was like 8 more teams at the time. It's like, where do you all think we should best deploy these teams? And the point there was that, and is that, we clearly don't know how everybody works. The law enforcement, it's not mutual aid, but it's kind of like mutual aid, especially in the desert. They might cover a station here, RSO might cover a station here. The way it's split up. And so really, we're just trying to provide information, provide data, say, how we're able to assist, and then really work in a collaborative way to best serve our community, and in this instance, to best cover our areas with the mobile crisis teams. So that was then. This is a little more recent in terms of our crisis team coverage. And, again, with the support of the board, with grant funds from the state, we've gone from 15 to 50 mobile crisis teams. The state has a rule, that starting in January this year, we have to be able to respond to a crisis within an hour. Because of our coverage, because of how we partner with other entities, we're now targeting 30 minutes. So we're aiming way above and beyond what the state is asking of us, and we're able to sort of blanket the community with these mobile crisis teams as a front door into our behavioral health continuum of care. Just some data about our mobile crisis teams, and this slide's a little acronym and widgy, but I think it's interesting. It kind of coalesces a couple of different threads. So we have the mobile crisis response team, so the MCRT. These are the OG teams. They're originally grant funded. The grant sunsetted. We realized how useful and helpful they were, and we continued these programs at great cost to ourselves. But these teams responded to the field, to schools, and to hospitals. Mobile crisis management teams, these are comprised of a behavioral health expert, a housing expert, and a substance use disorder expert. CBAT teams, these are law enforcement ride-along teams where we partner a behavioral health clinician with either a police officer or sheriff's deputy. And then the CAT teams, which is our newest program, and these are our partnering with AMR and EMS. And I think a couple of things. So we've built a mini continuum of crisis teams. So for example, you could envision a case where you get a call of someone in crisis and it's kind of a scary situation. So you would send out the CBAT teams with the thought process that if it goes not great, you have law enforcement is on site. And then if they come in and they're able to de-escalate the situation, or maybe it's an okay situation, you can call a mobile crisis management team or an MCRT team, and the CBAT team can go back into service, as it were. So we've consciously built out this ecosystem and layering teams on top of each other. But the point I want to make is when we talk about using less, that side of the coin, you look at these numbers here. So for example, MCRT, just because in front of me, we're able to divert 70% from hospitalization, meaning that 70% of those calls did not require hospitalization. MCMT, 74%, and you saw all this data there. But the point is this. So when I look at our data, it seems as if Riverside County has around 19,500 crises annually. So these are folks of individuals who are in crisis. And what we see looking at our mobile crisis teams layered with our mental health urgent cares in Riverside, Palm Springs, and I don't know what people are calling me here for. So we have three mental health urgent cares. We're able to provide significant diversions, meaning that we're able to use a whole heck of a lot fewer beds. So we have 19,500 crises. We're able to divert 14.5 thousand of them, meaning that only 5,000, and this is bad terminology, and I apologize, but only 5,000 of those folks kind of get through or require an inpatient level of care. And so that's, I think, just a really powerful way to structure a system. So we'll talk about build more, but the use less side of the coin is absolutely critical as well. Also on the use less side of the piece here, we've been really focusing, I think you've heard us talk about before, about our FSP programs. So our FSP programs are full service partnership programs. These are our most intensive, aggressive outpatient services that we provide, smaller caseloads per case bearing staff, a real focus on consumers who might be at risk for hospitalization, being unhoused, being arrested, those types of things. And what you see when you wrap appropriate services around folks and help with housing and placements, these individuals do much, much, much better. So here you see, hospitalizations decreased by 53%, arrests decreased by almost 92%. And I think the point here is that, it's not as if these individuals are suddenly getting much better at dodging law enforcement. But again, when you wrap intensive services around folks, when you help them with social services, when you get them into appropriate housing and placements, these folks do a lot better. And so again, just on the use less side of the coin, because those are such valuable resources that we have. Same approach, but this is so AB 109, if any of you folks are familiar with this. So these are folks who are involved in criminal justice system, but again, same type of setup, FSP, AB 109 type data, but you see significant decreases in hospitalization, significant increases in housing, help with employment, and just a real critical piece of it. So, I will pivot to the build more side part of it, which I think is what you guys want to hear about. But I would be remiss if I didn't kind of lay out the structure of how we look at the problem overall. So yeah, we got to build a bunch more stuff, and yeah, we have built a bunch more stuff and are building a bunch more stuff. But I think if we ignored the other side of it, you would always just be chasing your tail because you can't build enough. There's not enough funds. There's not enough this. There's not enough that. So we have to be as efficient as we can be. And from our perspective, that involves, again, right care, right time, right place. How are we best able to link folks with the type of care that they need? So this is our investing in innovation and building the future of behavioral health together. This has been possible, as I mentioned, and we'll talk about some details, but the team has gotten really good at going after competitive grants that are out there, and really be able to draw down, as many dollars as we can, stretch every dollar as far as we possibly can, and not just draw down the dollars, but turn it into actual projects where they're actual humans living in there. The downside is the actual projects are full, but we'll talk about that in a sec as well. So this is our crisis campus. This is in the city of Riverside. It has a mental health urgent care and a crisis residential treatment center. And so again, just a mini ecosystem around there, and actually off to the side somewhere, there's some permanent supportive housing units that are also grant funded as well through No Place Like Home, which I'll talk about. But I have this piece out here for a couple of reasons. It's hugely beneficial in the way our system of care operates. Our psychiatric hospital is nearby, and this functionally is a release valve, and that we don't need to send folks to our inpatient unit or our psych ER if we can more appropriately manage these folks in mental health urgent care or a crisis residential treatment center. The other part, and this is just, I've been beat on a lot, when you go to, and I'm sure we all have, when we go to communities and you want to build, heaven forbid, behavioral health stuff, they have this idea that it's really scary, looking like jail, imposing, drab, ugly type stuff. And that's really not what we're doing anymore. We're really building projects that are beautiful, that fit into the aesthetics of the community of where they're placed. And so this project actually won a Riverside City Beautification Award. I think it was second place. We still got a beautification award, so we were pretty jazzed about that. I still won first place, but we can't win them all. One of the projects we've been really going after is No Place Like Home. Marcus will keep me honest here, but we've drawn down funds to build over 400 total permanent supportive housing units for folks with serious mental illness. And on top of that, because the way the program is structured, we have allowed developers to leverage those funds to build over a total of over 1,000 affordable housing units. And so, we talk about homelessness being a housing problem. We've talked about that book, or we've read that book, or we talked about it somewhere. I can't remember. I think, yes, we focus on the folks with SMI. I mean, that's sort of our lane, that's our wheelhouse. But projects such as this, we really feel helps the larger community as well throughout. Up the road, and I'm so bad at geography, but this is Roy's place. And so this is a 92-bed adult residential facility that is built in Palm Springs, is a long-term recovery and stabilization, prevents repeat hospitalizations. And this was actually, we won a couple of these. This is the 2023 NACO Achievement Award winner. It's a beautiful facility. And I might get my math wrong, which is I'm embarrassed about, but we did the math before. And so an acute hospitalization day costs us X. A step down in IMD, which is just our level of care below that, costs us I think a fourth of that. And then Roy's costs us a tenth of that. And so long story short, it costs us like a 40th a day. And those are old numbers. The newer numbers is actually much more in favor of a place like Roy's. But when we talk about the fiscal challenges we have, how do you draw down every dollar you can? How do you stretch every dollar as far as you can? If you can move people to the right level of care, if you have folks who are appropriate and needing this level of care, it's a much more efficient system overall. So this is a real important place in our overall continuum. So this is Roy's. Are they saying how bad we're doing, or what's going on over there? I'm getting concerned. Another project here is the ARC, or the Arlington Recovery Community. And so this is a residential diversion recovery facility for substance use disorder. This was done through a CHAFA. It was a CSI Round 1 grant funds. And if you guys ever been up there, this is an old juvenile sex offender building. And if it wasn't haunted, it looked like it should have been. It was like super scary. But now it's, a beautiful facility. It's hugely helpful. It also houses the first sobering center in the Inland Empire. And I don't think our IHP friends are here today, but that's one of the community supports level of care in Cal-AIM and that type of stuff. But the first sobering center in the Inland Empire, this one a 2022 NACO Achievement Award winner, and is really just showing how helpful and necessary it is, this type of facility, A, and then B, also the special sauce, I think, in how the teams work in the facility, work with the facility, because we have much better outcomes than other places that have a residential facility and how it's set up. I can talk more about that, but essentially this is going great. It allows law enforcement to drop someone off instead of taking them to jail, allows ambulances to drop someone off there instead of taking them to jail. It again is an ideal of how to use the system most effectively, efficiently. This is the Restorative Transformation Center. So this is a 30-bed facility. Here we took an old DPSS building and converted it into the RTC. So Residential Diversion Recovery Facility. I don't know how familiar you all are with this, but a big challenge that the state is facing, we're facing, is with a subset of consumers who have been found incompetent to stand trial. I don't know if any of you guys do that type of stuff. So it's a criminal justice piece, but these are folks who are found incompetent to stand trial. Huge issue in that space. But this project has allowed us to more effectively care for some of those folks. Again, this was done through a CHAFA grant. This was CSI Round 2. And so we took an old, I think abandoned DPSS building and turned this into the RTC. Franklin, I think this was what actually prompted this. So we'll tell you a little about Franklin as well. I told you how helpful Roy's was, again, that ARF, and so it was so good. We're like, well, we need to have a Roy's Jr. then. Unfortunately, they don't let me name anything, probably for the best. But this is a new program that we opened in August of 2025, 84-bed residential facility, again, adult residential facility level of care. This is a beautiful facility, and this was done through BRAE grant funding through BHBH, the HIP part, and then the Santa River funds as well. Woo woo! Special shout out to this group for this project. Tanya, you've been there. It's a really cool place, and it is critically necessary because and I think I'll talk about at the end. But essentially, we open all these programs, and if you come back a few weeks later, they're full. You speak about just the pent up, unmet need in the community, and so we keep chipping away. We do find that as we open the different levels of care, the different parts of the continuum of care, we're better able to slot folks into the appropriate level of care, and that makes the whole system work more efficiently. And I don't mean to derail even further, but just from a high level. So we have people at our inpatient level of care, and they may be known as like conserved. So they're found by the court to be gravely disabled, and so they need to be placed somewhere. If we don't have the ability to place them, to step them down from that level of care, then they take up an inpatient bed they don't need. They take up an inpatient bed they don't need. That means people in our psych ER can't get from the psych ER to the psych inpatient level of care, which then means that the psych ER overflows, which then means that community members can't get into the psych ER, which means that community ERs overflow, and then it's all kinds of badness all the way around. So I think when we talk about these specific programs and these specific grants we've managed to draw down and blend and braid, but conceptually I think it's pretty simple. It's just looking at the different parts of the continuum of care, seeing where the gaps are, seeing where the programs are that are out there you can go after, and try to knit it all together. And then if you've heard about Harmony Haven in other contexts, so this is in Beaumont. And so right now we are working closely with the executive office and supporting DPSS, but we have staff on site there now. So a behavioral health specialist, a TAE peer support specialist, and then when our mobile crisis management team responds if there are issues or crises there as well. However, I think to do what we wanted to do from a larger scale, we don't necessarily have the physical plant there that we're able to do. So we've been fortunate in that relatively recently now we drew down grant funds through what's known as Prop 1 B-CHIP, and this will allow us to build the Children and Youth Wellness Center at Harmony Haven. And so this will have a 30-bed residential SUD program for adolescents, which is the first one in the county of Riverside. The 16-bed PRT, which is essentially a crisis residential treatment facility for kids and teens. STRTPs, if you guys are familiar with that space, and then mental health urgent care as well, and then an outpatient clinic for the community. So again, it's sort of what do we need? How can we actually make it go happen? And for this piece, we're able to draw down some Prop 1 B-CHIP funds. This one is also a near and dear. A lot of these are near and dear to my heart. They're all near and dear to my heart. But this is maybe near and dear to Greg's heart, because I hear him chuckling. So this is the Wellness Center. This is the I mentioned at the start of this conversation, the inpatient psychiatric facility that needs replacement. This is that replacement. So this is a 100-bed behavioral health facility. It'll be state-of-the-art. We'll have kid capability, which is huge. Again, right now we got to ship them off to places other than Riverside County. Here they'll be able to stay closer to home, family, friends, loved ones, and get the care that they need. Also, this one is on the medical center campus grounds, and so we have that synergy with the rest of the services of the medical center. This again was supported. The only way we're able to do this is we got Prop 1 B-CHIP grant funds, and so this is slated to open in 2029. And so, just from a high level, what we build and we're building together, we've gone over 7 major capital projects here. So the ARC and Sobering Center, the RTC, Roy's Junior, Harmony Haven, the hospital, Wellness Center, and then the Wellness Village, which I'll touch on. But in terms of impact, we're able to open over 400 supportive housing units countrywide through No Place Like Home, countywide. We expanded access to crisis, inpatient, residential, and step-down care. These new facilities are adding hundreds of beds and treatment spaces countywide. And again, one of the main points here is the infrastructure investments really prevent hospitalizations and work on long-term recovery. And so what it means, we're diverting thousands upon thousands of folks from hospitalizations. Thousands more are being stabilized through care and housing. And really, we're building a better system. It's a system that meets folks where they are and helps them recover where they live. And this is possible through all the efforts of the team, going after all the grant funds that are out there, be it B-CHIP, CHAFA, No Place Like Home, and others as well. To put a number on it, so we have in the last 5-6 years now opened 858 beds. There was a time during COVID where we had opened 500 and odd beds. And at that point, at a point in time, we had opened more beds than all other county behavioral health departments statewide, and actually opened more than all the county behavioral health departments statewide combined had opened at that time. And we've just continued to go after it and build a bunch more beds. So you see all these things here, those 858 beds spread throughout the county of Riverside. Not done, and clearly more needs to be done, but we're already slated to open an additional 901 by the end of 2029. And actually a chunk of these will open in 26, 27, 28. And then the last one here, the last one on this slide is the Wellness Center of the hospital. And that is slated to open in 2029. So again, the idea is, going after the funds we can, building out the system of care, kind of marrying as best we can the need with the service provision, being creative in how we look at the problems and how we structure our strategies to attack those problems as well. And then finally, I just want to touch on the Wellness Village. I think this is a question as well, but we love all our projects. We love all our children the same. But this one is special. They're all special. But so this is going to open in Mead Valley. And what is a wellness village? So a wellness village at its core, it's a campus. It is a campus that has the full array of behavioral health services, substance use disorder services, access to physical health care, and different housing and placement options. But really, on top of this and interwoven into this is a focus on social determinants of health. I think one of the things we learned, going through COVID, coming out of it, working with our friends in public health, we learned things such as, your zip code can matter more than your genetic code. Disparate things such as tree canopy and green space have an outsized impact on your health and well-being. And so really, we look at the Wellness Village as sort of taking all the learnings that we've had and distilling it into the campus. So again, it has all the services I mentioned, but it has green space, it has tree canopy, it has parks, it has supermarket access, it has a pet hotel. We know for us, that's a huge piece because a lot of our consumers, their family members are their animals are their family members, and a lot of them will not accept care placements because they've been unable to bring their animal in. So this has been a whole thing. It's been more of a thing than I think we might have thought to start with, but we will have a pet hotel on our Wellness Village. We'll have, again, community centers where folks can kind of come in, and a big emphasis on educational training and vocational training as well. And so the idea here is, it is its own ecosystem. One thing I'll point out is that this model is being looked at in the state. At the time, we received, it was the largest round of B-CHIP awards for this project, but it's looked at as a model in the state. The state's told us that. We've had other counties essentially say publicly that they're copying the Wellness Village and maybe a smaller scale, but I think the idea makes a lot of sense. I think when we look at everything that we're facing as statewide together, this approach really makes sense in providing the best opportunity for folks to really recover and reintegrate back into the community. It'll also be super beautiful. If you guys have driven by the site, every time you go by, it looks better and better. Slated to open ahead of schedule, but slated to open to finish the end of 2026, start taking folks in the start of 2027. So that's something that we're very excited about. And I believe that is it. And I appreciate the time very much.
Wow. I think that's probably what we're all thinking is, yeah. So I'm going to open it up to board members and then public. Supervisor Spiegel.
Just want to share, he won't toot his own horn, but I'll never forget the day he came to my office with this vision. Now, can you imagine sitting there with no money and a vision that he has that is enormous? I have a hard time with seeing it on paper and visualizing the conception of it, but to watch the process, I think it goes back to all of us have to be vision focused and not let things deter you, because this man has stepped up and has done an incredible benefit for all of us, for the county, and has keep going. He's got his little cohort behind him back in the back of the room, and a few other folks that have just been there in support. But it also is about putting a team together. And I think he's a model that we should all look at. Don't mean to embarrass you, but I'm enjoying it.
Right. Oh, thank you, Supervisor.
But in all seriousness, is that vision, the focus, and being able to say, this is what we want. And if there's things that come in the way, you just got to keep pushing forward. And we just heard about some of those things in our way this morning, what Tanya was sharing, but just keep forward. And then when you said no action, when it's okay, because we're just going to make it go forward. And that's what it is. And this is really a good feel good today. Thank you for sharing.
Thanks, Supervisor.
Yes, thank you, Supervisor Spiegel. Any other, we'll go next. We'll go first to Board Member Alba and then to Board Member Roper.
That was the best overview I've ever seen about behavioral health. So thank you so much. The way you organized it and the way you laid it out, not only in pictures, but in what you're doing, was extremely valuable for those of us that hear about things here and there, but we don't see the big picture. And you really nailed it for me, and I think for some other folks. The one thing that, the whole time you were doing this, I was going, okay, how do we get connected? How do we get into the system? How do we, how do we get involved? So I think you tried to explain it on one of the slides. It was right after the Wellness Village Health Services. It was the one with the arrows going here and there.
Oh, yeah.
But I guess my main question, and I don't know if I'm just speaking for myself or for other folks, is many of us represent smaller agencies who would love to know how to access these services. Could you talk about that for a minute?
Yeah, no, I appreciate it. And we are, we provide a lot of county operated, county run services, but we also partner already with 140 community-based organizations. And we love them, we need them. There are tons of things that we don't necessarily have expertise in. And so we can, we can talk more offline, but we have RFPs that are out there almost continually based on what types of programs and projects we're doing. If it's something about caring for a consumer or how, a clinical conversation, we can certainly have that as well about how to provide access for services. But if you're asking from a perspective of, partnering with RUHS or being one of those CBOs, we can talk more about that. But there is a process. We do have RFPs for different types of services all the time based on location, based on service type. And so we need the help and we welcome the help and we're open to the discussion.
Is there a beginning point though for everything?
There is. If you go, and I can send you that information, but essentially we list like the RFPs are active at the time. And so it could be for a specific program. And then my sense of it is we have RFPs in terms of what we're looking for. Does the organization that you represent, do you align with that piece there? And then look into applying to see if there might be a fit there.
Is that something you could send out to all of us?
Yeah, we can.
That would be.
Sure.
Nice.
Make a note of myself.
Thank you. Okay.
Thank you.
Do you have any other? Okay. Board Member Roper.
I just want to, I've expressed this many times, but as a person who has lived experience from a father who committed suicide because of serious mental illness, the work that you all do is so near and dear to my heart. And I just want to say from the bottom of my heart, thank you so much from just as an individual, how important the work that you do is. And it's for your whole team countywide. From a city's perspective, we can't thank you enough for the partnership. We host one of your crisis teams in City Hall for the subregion. We work with your CBAT team. You have staff on site 5 days a week at the Home Key project that we partnered with the county. You mentioned the clinic. You guys are just such great partners. And I want to take a moment to acknowledge some of your leaders. Obviously, Marcus Cannon is phenomenal. A shout out to Larissa Villarreal. And I can't say enough about Heather Sylvester, who's just great when it comes to the crisis teams. Thank you, thank you, thank you.
Okay. Other board members? Director Jefferson Gilpa.
Hi, I first want to say it's so beautiful to see the entire ecosystem. I think each of us are kind of in our own kind of sphere of where we serve, and it's nice to kind of to see it from kind of a drone's perspective. So thank you for that today. I also just want to say and acknowledge the weight of the role that you carry. And I want to just take a moment from one person in a really hard job to another person in a really hard job to just say thank you. This is a really hard season for all of us to stand up and be leaders and to believe in the community that we want to see. And those of us on this side of the table could not do the work that we do without a really strong mental health support, right? Like homelessness equals trauma, right? So just the act of losing home requires someone to engage with mental health support. And so I just wanted to first just pause and say thank you. And I know you're not comfortable with it, but too bad. We just sometimes need to sit in the truth of recognizing what a powerful role you play in making sure that Riverside County looks like the community we all want it to look like. So thank you. And thank you to your team, because we know you don't do this by yourself. I also just wanted to mention how powerful it has been for us. We specifically at Family Promise serve families to have a robust program, particularly with one access point, the CARES line, to be able to care for every single facet of a family, whether that be grandma, mom and dad, or kiddos. And just to, I know you know the power of the work because you did it, but it really makes it so nice for those of us who are juggling all of the challenges of a family to have one number to call and say, oh yeah, okay, so great, we're finished with this person. Okay, now can we move to this person? And to be able to, on the other end, have the flexibility to have access to children's and adults and substance abuse and, you know, geriatrics all in one system. So I know that you took that on, kind of streamlining and dovetailing that, but from end user perspective, it is powerful to literally have one number to give my team to be able to access mental health services from every facet of needed. So I thank you for that hard work and all of the details that we did not have to see that you had to do in order to make that one number happen. But in the field, it is powerful to be able to make sure people get the mental health services that they need as quickly as possible. So thank you.
I'll just comment. I appreciate that. I'll tell Brandon Jacobs that because he's helped spearhead that, and that was not easy. To your point, so he'll be glad to hear that it's helping folks because that's it makes sense, right? Because you guys have enough to do, and if we have you call like 50 people, it's hard to do your job, and so we tried to. It's still more to do, but try to streamline as we're able to.
Thank you. Other board members? Okay, Tanya?
Yeah, I'll keep my comments short, but I feel the need to speak, especially after being a part of so many different convenings at the national level, at the state level, where we're meeting with other CoCs who are just beginning to sort of bridge or make connections with their county behavioral health departments. Literally at the San Diego convening, I had leaders, other CoC directors pulling me aside and say, how did this relationship start? How is it that your county behavioral health department is your lead for the coordinated entry system and is managing all the calls that come to your continuum of care and is the entity responsible for facilitating those connections? How is it that they're on the ground with you? And I think that is the one piece I want to emphasize is there is no response that we currently coordinate, whether it's encampment, street outreach, emergency assistance, that isn't done in coalition with your team, Dr. Chang. And I've been in this position for the last 5 years, and I've known it no other way. And in a time where there is this major policy shift and an emphasis on more coordination with behavioral health services, and again, you've heard us say a need for us to be extra competitive. You guys have made it easy for us to show the work that we've already done. Also, I want to emphasize that while I can't speak to why we're seeing, speak to the cause per se on why we're seeing a decrease in homelessness, right? We know that there's a lot of correlations. I think a lot of the work that you guys are doing, the work, the different projects that you've highlighted, the response that you've built, Dr. Chang, is aligns with right, the decreases we're seeing. We had a 19% decrease in our unsheltered homelessness. Last year, we saw an increase of, for the first time, a decline in the number of people that had died on the streets. I think it was upwards of 20%. We're expecting another decrease in the number of people that have died this year as well. And again, can I say it's a result of this, but no, not definitively. Marcus Cannon, who always reminds me we have to be careful and cautious and sort of look at all of the different data sets to point to the story, but there's a correlation here. And the fact that you have grown your mobile units from 15 to 50, and they're going and meeting people where they're at and providing these critical services, I think speaks to it. So just know that I am so, so grateful and that I am using what you guys have built here to share with my partners who are in this work to say, look at what's possible. So thank you.
Okay, Greg?
I'm going to give you kudos. I know you don't like it as well, but Tanya stole my thing on integration with the CoC, but also I chair the county's Community Health Center Board. And you talked about the standalone clinics, but a lot of credit goes to Dr. Chang and his team as well on the integration of behavioral health within those clinics. All of our clinics have an element of behavioral health. We're recognized statewide for that as well, and also amongst the FQHC community. So applause to that. I also too just want to give a shout out. As most of you know, I used to work for Supervisor Perez, and I will tell you that whether it was a call to Dr. Chang or mostly Marcus, or Ryan, the responsiveness out of that team is absolutely amazing. And I know, there's a lot of power, as Supervisor Spiegel knows from the supervisor's office, and staff does answer quickly. But you were really cognizant about what the needs were. And one of the best examples was the need for services in Blythe and how quickly your team addressed those issues. And that community realized it. So again, great work, Dr. Chang.
Thank you. Board members, any other comments? Okay, members of the public present, is there any comments? Members remotely?
None, just kudos.
I'm gonna wrap it up with my comments. And I'm just thinking back to almost three decades ago, okay, when having these conversations with Director Ryan. So I look a lot younger. No, but yeah. But I started very young. But just thinking back to all the things that we were asking for back then, the sobering centers, the facilities that looked welcoming to families, that weren't scary, having the adolescent centers, and now you're looking at having for the younger kids. These things take so much time, money, and I totally agree with Supervisor Spiegel about the vision that you have to just keep keeping your North Star and making sure that it doesn't deviate when all these other problems come up. So I have to tell you that, yeah, I am just so grateful that we have had the leadership and the leadership that we have now to be able to keep our focus on the people that we're trying to serve, and that you are so open to ideas from others and partnerships with others that can't even fill those gaps that exist. So I have to say thank you so much. I do have a question. I was a little bit trying to figure out the riddle of the old abandoned building, the Restorative Transformation Center. You didn't say where that's located. I was thinking it was Indio, but I'm not sure. It's not Indio?
So the RTC is in the city of Riverside as well. the
Oh,
Restorative
okay,
Transformation.
okay.
Yeah, it was an old DPSS building that wasn't being used, and we just renovated it with grant funds.
Okay, well, it looks great, and all of the facilities, I think you accomplished what you set out to do to make them welcome to our residents and all the families that are in need. I totally agree with what Director Roper said. So thank you, and thank you for showing us this information. I know we've been waiting for a couple of months, and it was worth it to have it today, to have the time to be able to really take this in and to understand it and to appreciate it, to all the work that you've done. So thank you.
Thank you very much.
Okay, so we will go back to the next item is, let's see, 5.0, new business, Riverside University Health System. Okay, that's the one we just covered. And so we're at the end, right? Okay, so director's report. Tanya, do you have?
Nothing additional to
Nothing
report
share
out on.
after that, right? It's just like, wow. Okay, so board chair and vice chair recognitions. Tanya.
Take that. we wanted to take some time as we approach the end of the year to recognize our two chairs who have served in this capacity, I will say, for a number of years. First, we wanted to recognize Leticia, who, as I mentioned, has acted in this capacity since I've been with the department, and we've been acting as a CoC lead agency for the last 5 years. But I think it's important to note that she has served as a chair far before that for many years. Leticia, I don't know if you know the total number of years, at least, I want to say over 10 in total.
Oh my gosh.
But she has been incredible, and you can imagine that when we took over in COVID and I stepped into this role, she has been such a huge guiding force. She helps us prepare for these meetings and has really helped guide the way the board and our coordination efforts have played out. And again, like today, the last 5 years have included a lot of good conversations, but also a lot of difficult conversations. So as a token of our appreciation, Leticia, we have this key trophy that we wanted to present to you. And Greg will be walking that up there to you. Not with us today is Ben Haregi, Dr. Ben Haregi with IEHP, who has been serving in a vice chair capacity and who we also have a special gift for. We did notify him that we would be doing this recognition today. I know he's had a couple health issues, but is doing well. So I wanted to take this moment to also just acknowledge what a critical partner he has been in this effort. Our managed care plans are a strong provider supporting our housing work with resources, but also coordinating the vendors that they have, providing community supports and enhanced care management to all of our clients. And Ben has really been the glue from the very beginning that has helped connect those dots. So we're thankful to him, and we'll make sure that this gets to him. But again, in that same spirit, to all of our board members, I want to thank you for remaining active with us in our mission and continuing to be flexible and jump in and come together even on short notice when we need action to move certain efforts forward. So with that, Merry Christmas and thank you all.
Okay, well, that was very nice, and I'm still shocked. So, yes, you left me speechless there. So thank you. My job is so easy, okay? Because with your work, Tanya, and your team, all the time, it's so easy to do this, and the respect that we have for each other and the work that we're all doing. All except Dr. Chang, that was a little troublesome last month, but but it is so easy to chair, and it's a privilege to do my little part in helping our community to make our community better. So thank you. We're moving on to the next item, which is a call for agenda items for the next meeting. Any board members have any items that they would like to have agendized?
Only if it can top Dr. Chang's.
Yeah, no, that was hard to follow. So yes, thank you very much. So if you have any ideas between now and then, make sure you reach out to Tanya. And I'm sure we have a lot of business to talk about in the new year. So thank you, everyone. Happy holidays, and was wishing you a happy season, and see you next year.